My name is Victoria MacDonald. I'm the Health and Social Care Editor for Channel 4 News, and I am chairing the session sponsored by the ABPI, and it is about vaccinations and the vaccination program. And it will be discussing the priorities for the future delivery of NHS vaccination services and considering what steps need to be taken next. I know every single one of you in this room will have read the NHS vaccination strategy, so we won't need to go over that. Or maybe some of you haven't had time, but it's online, of course. Let me introduce very quickly the panel. So next to me is Steve Russell, who is the Chief Delivery Officer and National Director for Vaccinations and Screening at NHS England. Keith Morton, Head of Programme, COVID-19 Vaccination Programme, NHS Lancashire and South Cumbria Integrated Care Board. And next to him, Deborah Smith, Health and Safety Manager, IPC Lead, Ryesdale Estates Limited Nursing Homes. And last but not least, Ben Lucas, Managing Director, MSD in the UK and an ABPI board member. So the vaccination strategy, which came out late last year, the strapline was, and I've been pondering this all day about whether it was a good one or not, was booking a jab as easy as booking a cab, but any of those who live in London will know that Ubers aren't always that arriving on time these days. So the aim was to make vaccination as easy as possible for everyone and to improve vaccination levels in groups that are less well served by vaccination. So in this session, we're going to discuss how to do that. Each of the panelists is going to give us a brief introduction, and then I'll ask some questions, but I will always welcome some questions from you too. So can I turn to you?
Thank you very much. I agree with your Uber comment, by the way. We published the strategy because we felt it was timely to do so after the COVID pandemic and the learning that we'd taken from that particularly difficult period. But basically, without rehearsing the strategy, what it basically says is vaccination is one of the most effective ways of preventing ill health and saving lives. It is second only as a public health intervention to clean water. So it is, I am a bit of a convert, as you would imagine, and we've got an opportunity to go much further because uptake of vaccinations has been declining, and there are new vaccines coming out on the horizon that can prevent against other diseases. So it basically says we should try and do three things. The first is a single front door into vaccination, so people knowing what they're entitled to, knowing the programs that are available, and being able to book an appointment through that single front door in a way that makes sense and is convenient for them. That's sort of important, but not really sufficient. And so the two other points that the strategy makes kind of plays to your point about, was the strapline the right one? Because there are a group of people who, no matter how we organise vaccination services, will find their way to them. People like me. And if we organised it in a certain way, even if it was different to how it is now, I would still probably find my way to a vaccination centre or a service. What the strategy tries to focus on is the people that the NHS does not serve well, and who have not come forward for vaccination over a number of years for a variety of different reasons. And actually, those are many of those people and those communities will not use the NHS app, and actually probably can't afford to use a cab. And so what the strategy basically says is having a single front door and a convenient set of access through general practice and community pharmacy is important, but actually the real benefit is in community-based services in places that do not look like a healthcare setting, run by people from the community in whom people have trust and confidence. So it makes a pretty big play on what we describe as outreach. And the third thing it says is, whilst we are massive proponents of vaccination, that is not top of everybody's list. And so, linked to the second point, vaccination should be part of a conversation about health and well-being, as part of a package that speaks to the issues that people are, that care about. I remember somebody saying to us when we were doing some of the research on the strategy, look, getting a jab is not top of my list. I can't afford to heat my home. So you can invite me all you like, but actually the issues facing me are these things. And so what the third part of the strategy says is you have to meet people where they are, not where we would like them to be. And so vaccination being part of a much broader public health offer set in a way that makes sense to the community. So we ran a bunch of health events where the people had said, actually, what I'm interested in is perinatal mental health. So you organise support around that, and you might have 1 or 2 people who get a vaccination. You might have none, and that's okay, because it's about building confidence on the issues that matter. And then the final thing, and I'll stop, is vaccination is often seen as somebody else's job to do. The NHS touches tens of thousands of people every hour. And what we also want is, in those places that people present and touch healthcare professionals, that in addition to the thing that they have come for help with, there's an opportunity for a clinician, the person who's looking after them, to say, have you had all of your vaccinations? Let me check what you've had. Have you taken up all of your opportunities for screening? And to prompt people where they may not have taken up all of those opportunities, and not to send them away and say, actually, do not go and book it in your general practice, but just to give it to them there and then. And if we do those 3 things and loads of other stuff, we hope that we might get to one of our ambitions, which is to eliminate cervical cancer, which is driven by 2 things: cervical screening and, more importantly probably, HPV vaccination. So that is like a real-world example of where we want the strategy to basically impact on people's lives.
Thank you. Can we just put something to bed while I've got you here? There was a recent article saying that there'd been cuts in the vaccination programme at NHS England not too long after, of course, the strategy was launched. Have there been cuts?
No. So the public health budget that we're responsible for has grown year on year. And without getting too boring about it, what we normally do is allocate that budget, about £1.34 billion, to our regional teams who commission services. And we'll probably get on to the role of ICBs in the future, because we think that is where it should be best placed. We have held back some of the money in terms of the allocation that we've given, but the reason we've done that is because over the last few years, money has gone up, uptake has gone down, and so in effect there have been underspends that have been supporting other parts of the NHS, and what we've done is create a public health reserve that we want regions and systems to spend on promoting confidence and improving uptake. So that's the long and short of it. That's not quite how it got reported.
Yeah, okay. Thank you. Keith Morton and Deborah Smith, you're going to do a double header, I think, but looking at a project to vaccinate people in care homes. Do you want to go first?
Yeah, thank you. Just following on from what Steve's mentioned, really, in regards to the strategy, what we're going to showcase in evidence today is how it's happening in real time, and we're going to give a case study in relation to that. As part of that, or the foundation of that, is NHS England has set up the demonstrators working group, collection of systems who have embarked on innovative cases of work, really, and the objective of the demonstrators working group is for each individual system to showcase that and to learn from each other, troubleshoot, and the resource within NHS England and the team from the regional college has been excellent, really. Quite a transparent platform, and the overarching learning from that has been, from personally working, has been a breath of fresh air, to be honest. So the enablers and the mechanisms that are in place from the vaccination programme have allowed us to implement a test of change within nursing homes. As Steve mentioned before, the strategy lays heavily on what is going to be done outside of the core offer from within primary care, outreach if you like, if you want to use that correct terminology. So as part of this, there was a vision from a colleague within our system who felt it's the right thing to do for trained professionals within nursing homes to vaccinate their own patients and staff. There is lower than would be liked vaccination for staff for COVID and flu in nursing homes across the board, and across all health and social care for that matter. So we went on, we started the process, heavily linked in with NHS England colleagues and regional colleagues to discuss and explore the art of the possible. Contractually, there was a finite period of time, so due to the finite period of time, we were unable to contractually mobilise this venture, but we came back with good suggestions and enablers that would allow us to work around that barrier, if you like. That being, we met with local PCNs and devised memorandums of understanding to substitute what would be an NHS standard contract. And that was through the suggestion from NHS England. So you can see from the very early stages the collaborative working and the vision of the strategy is being implemented. So with that in place, there's a lot of sort of permutations of what we could and couldn't do, but we got the right assurance and agreement and buy-in from NHS England and our regional colleagues, so we embarked upon this venture really. There's a number of selling pieces and USPs, if you like, to this venture. A being the uptake for residents increased for COVID. The flu uptake for residents remained the same. But the USP, if you like, is there was a 6-fold increase in staff vaccinations for COVID and just under 6-fold increase for flu. There is a multitude of reasons why they were, and that's, I'll bring Deborah in to explain that, because she's the boots on the ground in her team, and it's just worth mentioning, none of this would have been possible without the endeavour and hard work of the Rysdale group, really. I think it's a key point and key time to bring Deborah in to just explain that for you, really.
Yeah, no, of course, go ahead.
Hello, everybody. So the ICB approached us, as Keith said, as regards to doing our own vaccinations for residents and staff within our care home group, which is a small care home group in the Lake District with 340 residents and about 800 staff. And we took it on board. And we worked. There was three of us in the team, so we worked together. Throughout the vaccination program process. And what we found was that because the residents, for one, knew us, we knew them, we knew the staff, they knew us. We were able to sort of deliver more person-centred vaccination, and that we made it fun in a way for the residents and for the staff, and even staff that were concerned about having the COVID vaccination that had never had it before. Maybe they hadn't been in health and social care previously. They would actually have it. You know, for example, at the point we was going round, there would be a contractor maintenance, and they wanted it, so they took both vaccinations because they knew us. They were content around that, and the flexibility of it as well. You know, because we're sort of in and around the residents and in and around the homes, if a resident weren't feeling up to having the vaccination that particular day, we'd make arrangements to go another day that suited them, or later on in the day. The staff, it meant that they didn't need to sort of make appointments with the GP or with the local chemist. We could just do it in situ. They could either come to us, we had like clinic days, but predominantly we went around the homes. We did the vaccinations there and then. We'd do the same for night staff, so we covered the whole staff basically, including maintenance, kitchen, catering. Everybody was involved in it. Yeah, it worked out really, really well, and we were really pleased with the staff uptake more than anything. because there had been previously staff that were a little bit scared of the COVID vaccination, or they might have had it right initially, but didn't want it again. But they had it. They were happy to take it. They were, because they knew us and they trusted us. It's hard to explain, really, but...
No, we saw, I mean, I saw it when filming in Bradford, for instance, and the use of the mosque. So it was the imam, not the doctor, who was explaining, you know, how important the COVID vaccine was.
Yeah.
And this is another good example of, you know, sometimes a paternalistic approach doesn't work. You know, you want to be talking to your peers about it. Let's see. What do you think about this, Ben?
Yeah, so thanks, Victoria. So look, I work for MSD, and I think we're relevant to this conversation because we produce life course and develop life course vaccinations across the life course. So our experience runs through pediatric programs, adolescents, young adults, as Steve referred to in HPV, and in the adult, late adult section with pneumococcal. So, and I also have a role sponsoring and leading the ABPI's vaccination group, where we work across industry to ensure that we're doing our part, playing our part to ensure the UK has a world-leading immunisation programme and an ecosystem in which anyone who can be protected is protected. Now, on reflections on the strategy, look, the reality is we need to take action now. The industry have been calling for something like this since 2019, when the UK lost its measles elimination status. We have seen, as Steve alluded to, declining vaccine coverage rates, which means declining protection. We've seen an increasing divide. In our own programs, we see variants across the country where potentially the highest rates of vaccination might be just half that in other areas around the country. So variation in care and how we communicate to patients who are underserved is really important. And then importantly, as a provider of vaccines to the system, you know, that we end up in a vicious cycle, because what happens is the demand for the next order, the next tender, is lowered because the vaccine coverage rate at the moment is low, and hence our ambition is going down, not going up. And I think that's where the strategy comes in. For me, it's exciting. I think as an industry, we're excited because it unifies all of the stakeholders around delivery, including industry, with a call to action that I think we can all get behind, which hopefully sets an ambition for what we need to have in the future and the ways we need to work. The elements are things that we can all get behind, no doubt, and trying to work out how industry can play our role is one of the key ways of having this conversation, reasons for having these conversations. So I think there are a number of ways industry can play our role. You talked about cervical cancer elimination, and I've just come from a session that our company were working around the race to elimination, which is a program in which what we're trying to do as MSD is to highlight great practice that already occurs in the system, because actually at a really granular level, if you can just spread that great practice, there's not a high barrier to change. It's just about people learning and understanding. And hence I believe in a way in which industry can celebrate and share great practice is really important. We also have a role, we are professional communicators, that's the reality of what we tend to do. And so we have a role in how we can understand and articulate value and benefit to communities that are underserved or are harder to reach in some way. I think we've got resources that are dedicated that we want to be able to do something to change on that front. And then lastly, I think there is a big role for us to play around data, around being able to help the system to be able to collate data, visualize that data, and then represent that data to be able to track progress, because ultimately that's what we want to, that's what we're going to need if we're going to realize that ambition of trying to protect everyone that can be protected. And the last thing, I guess, is all of this, which is really what you said, Steve. You know, for an organisation that have medicines as well as vaccines, I always find it somewhat frustrating when I have a difficult conversation on medicines around value and ensuring that the system is getting value, but on vaccination I see this way in which we're leaving value on the table. We're simply not delivering the system all the value we can because of low vaccine coverage rates.
Interestingly, you haven't talked about international examples, and I know the NHS is of course, you know, there aren't many other systems like this, but we also know that vaccine coverage is a problem across the world at the moment. We know, for instance, that measles is not just happening here, it's happening, you know, virtually everywhere. Are there any lessons that NHS England that could be incorporated into the vaccine strategy that you've seen elsewhere, or are we doing it as well as could be done? Or obviously not that well?
So look, there's lots of good things about the UK's vaccination system, and a lot of that is about having a public narrative which keeps confidence with us. I think that's really important, and certainly something I would advocate. But actually, Victoria, I actually think the debate needs to be at the other end of the scale, or the discussion needs to be at the other end of the scale, because I think there's fairly unanimous belief now in the value of vaccination and widespread effective vaccination programs. There is a universal acceptance that or unacceptance that it is not reasonable to have the level of disparity we see. The conversation is literally on the ground granular. How do we persuade people within their communities, within their places of work, to be able to understand the day-to-day conversation and to take that step to take action and gain access? And then how do we ensure that we can make it lower the barriers to entry and ensure we're giving vaccinations in the easiest way to those people? So for me, rather than having a big international conversation, I actually want to have a really, really granular conversation on the ground and then spread that right the way across the board.
When I was looking through the strategy, there was a lot about the use of the NHS app, and that has come up several times this conference. How do you think that will feed into the conversation? Do you think that that's a core element of how you're going to approach it?
Yeah, so the app will be definitely part of that front door. And one of the reasons for that is there are three things that affect uptake. They're well rehearsed by World Health. So it's not my work. World Health Organization are really clear, but we see it in practice. So it is the offer convenient? Can you get a vaccination somewhere that is convenient to you around your life? The second is confidence. So do you feel that the vaccine, the medicine you're being offered, is safe? Or do you worry that it's going to cause you harm? And the third thing, which is, I think, certainly from our work, probably the more material issue at the moment, is complacency, which is, if I get it, is it really going to affect me? And if you look at the vast majority of the programmes where we've seen a decline, complacency plays the most significant part. So some of us, looking at the audience, probably not many in the audience actually, some of us will remember polio as a disease and will remember what it did to people. It paralyses people. Measles can kill children. That is not part of the fabric of our current attitude and understanding. So polio vaccination rates dropped because people thought it had gone. We talk about measles elimination. That means it's gone. So people then think, well, why am I being offered a measles vaccination? It's gone. It's been eliminated. So I agree with the point on narrative. And I think when your point about international experience is really interesting. So we did quite a lot of international comparisons as part of the strategy. Sadly, all on Teams. We couldn't jet off and look at different parts of the world. But most countries see the same challenges that we do. And interestingly, in one of the European countries, schools on entry, they ask parents to show that their child has been vaccinated. And vaccination rates for preschool kids is really high in that country. Now, when we were talking to them, they said, actually, what's happened is people think it's mandatory. So they think that you can't get your child into a school unless they're vaccinated. It's actually not true. It's a well-intentioned, good-spirited, has your child been vaccinated, and if not, can we help? But people think it's mandatory, so they are tending to do it. Now, we're not in that place at all, and neither do I think we should get in that place. But it is all about addressing that point on complacency. So there's a big role in terms of broader public health education in schools, in families, and whether that's about diabetes, obesity, vaccination. So it's part of how do you keep yourself well, how do you prevent some of these really terrible diseases, and we avoid what's happened at the moment, which is measles vaccination rate has increased by about 23% in January, February time compared to the previous year. But it went up because children were being admitted to hospital, being harmed. And the same is happening in whooping cough. Babies are dying. That has been reported. People think it's therefore a danger, and they are coming forward for vaccination. So we need to try and, we don't want to scare people, but that, you know, these might be Victorian time diseases. They're still here, and there are new ones that are coming down the line that could be, again, intervened on through vaccination.
I was thinking about this, Deborah, when, you know, thinking about the work that you two were doing, and it came up quite a lot during COVID about the hesitancy amongst carers and NHS staff, and perplexed a lot of people, I think. Where do you think it came from?
I think a lot of it was because it was actually made mandatory. And I think that upset the staff because they weren't given the choice, or the choice was you either have it or you don't work in care anymore. So, yeah, that's probably where it come from. So they sort of left a bad taste in their mouths, basically. And it's still there. It is still there.
Well, you could argue it wouldn't have been made mandatory if they were doing it in the first place, if there was enough uptake. So there was something about the messaging not getting through to this particular group of people, or
100% agree. I mean, we've been, obviously before COVID, it was the flu vaccinations. So it was, I think it was 2019, was it, that it became free of charge for social care workers. And so we were plugging it even more, that the staff get the flu vaccinations, but the hesitancy was there for that also, and the uptake was quite poor, to be honest with you. So I think it's just generally around immunisations, but as I said before, the staff seem more comfortable about it now, and I know it's because of what we've done, what Keith and the team have done, and Rysdale, by vaccinating in this manner. The staff have the uptake, well, as Keith said, sixfold, which is a knock-on effect, because obviously people aren't unwell the same. We don't have absences, and Hooley residents the same.
We did start late, and we are about to run out of time, but I think we might have time for a few questions if anybody has. There is a mic just here. Thank you.
Thank you. Hello, my name is Anna. I'm a reporter for Post, the GP magazine. We reported in February that NHS England had set up 12 demonstrator sites to test new ways of delivering vaccines led by ICBs. So I was wondering if Steve could give an update on how that project is going in line with the vaccination strategy. Thank you.
Do you want me to go there?
Yes, please.
Perfect.
Yeah.
So exactly as you say, there are 12 across the country. They are doing lots of different things. This is one of them. What we've tried to do in those demonstrator sites is not say, here is what you have to do, because we're quite good at doing that, and it tends not to work. So instead, we've tried to take the attitude that hopefully colleagues have described, which is, we want you to test stuff that you think will work for your community. So don't be bound by rules. Of course, you have to be safe, but if you think there is something that will work, that is different, then try it. And our job is to learn from those 12 pilots and say, are there any lessons from those that mean that if we did something once across the country, it would be helpful? So one of them that is coming out from pretty much all of the demonstrator sites is data. So we know, down to person, street level, who gets vaccinated for COVID. We rolled that out to flu last year. We rolled it out to MMR through the course of that outbreak. And that is so important because it allowed us to identify the schools where we needed to focus. It identified the communities we needed to work with. But we only have it for COVID, flu, and MMR. So one of the key lessons that's come out of most of the demonstrators is that need for pretty real-time, person-level, street-level data, and that is not just owned and used by the NHS, it's owned by the person. You don't have to ring anybody up to know what you've had, and that we share that information anonymised with local government, who also understand their communities in a very different way.
Ben, you wanted to say something?
Well, just to amplify that, I think one of the biggest things we can take forward now is real-time data. Previously, it was always so lagged, you never really knew what you were dealing with, and that becomes really difficult for resources, because you could start to address a problem that was a problem 15 months ago and it actually isn't anymore, and then people get demotivated around it. So I think, to Steve's point, expanding that data real-time across the entirety of the national immunisation programs and ensuring that we can enable change in year, because actually what we've seen is the local immunisation teams are hugely agile. They'll just start programs which are, that's the issue, I'm going to do something different. And that will, piece by piece, start to bring together the whole program, I think.
Yes.
I just come in on that as well, just to give you, to your initial question, to demonstrate a timeline for it and where we are and how this venture's come full circle. The barrier that was in place contractually at the start of this venture has now been removed. So there was an announcement of a procurement process for the COVID vaccination programme earlier this month. That now enables this venture to be implemented contractually. We don't have to, as a test of change, use the workarounds that we used previously with the PCN groupings, etc. So that's just evidence that what's happening with the demonstrators site is happening in real time now, and will continue to do so. So that time frame has now enabled this to move forward, with the potential 6 more groupings of this ilk to continue for autumn 2024.
I'm afraid, frustratingly, we have run out of time, and I'm sorry. We could have talked for a lot longer, actually. But can I just thank you very much? It's interesting. I mean, I wish you luck, and I hope that this good practice spreads, actually, which is partly for what you're doing speaking here, but it's obviously been a very valuable exercise. And as a mother, of course, I'm always worrying about, making sure my daughter's got her vaccinations up to date. We were talking about this before, weren't we, about how actually, because through the school program, I'm never quite sure what she's had or, whether she is up to date. That may just make me a bad mother, actually. Let's just glide over that one. But anyway, really thank you for your time, and I'm sure there will be some people who want to come and talk to you afterwards. But could you please give your thanks to my panel?